It is my pleasure, my honor to be here. These are my disclosure, but my biggest disclosure is that I'm the chairman of the EASL-Clif consortium. So in my presentation, I will use a lot of data coming out from what we did with the Clif consortium in the field. And I will follow this agenda. First, some insight on the pathophysiology of decompensation and development of organ failure. And then I will try to give you a new vision, a new classification of decompensation in patients with cirrhosis that we are trying to introduce in the knowledge, in the literature. We will be successful, I don't know, but we hope that we will be. So I grew and I developed all my career thinking that the only driver of decompensation was a progressive increase in portal hypertension, a related progressive derangement in the cardiovascular function. So splanchnic arterial vasodilation, inadequate cardiac output, and a related progressive increase in the degree of activation of vasoconstrictor, sodium and water retaining factor. I think that it was the same for Richard. A progressive increase in portal hypertension is a powerful driver of decompensation, but it's not the only one. And I'm stating this on the basis of the following. Number one, it's not true that in the most advanced phases of the liver disease, there is a progressive increase in the degree of activation of vasoconstrictor and sodium and water retaining factor. Number two, we are able to modulate this factor. We can reduce plasma renin activity. We can reduce plasma aldosterone without obtaining through these changes any significant result of the clinical ground, no reduction of the rate of complication, no improvement of 1 year survival. Number three, the most important, during the last 10 years, we developed a new definition, a new syndrome that can occur at any stage of the liver disease, but particularly in decompensated cirrhosis. I mean acute-on-chronic liver failure, which is characterized in patients with cirrhosis by acute decompensation, development of organ failure, and a mortality rate higher than 15% at 28 days. So let me highlight that a patient may develop organ failure, and so ACLF, even in presence of a normal degree of activation of vasoconstrictor factors, but never in absence of inflammation. And systemic inflammation is not only present in patients who develop ACLF, it's present also in patients who develop a simple acute decompensation. But let me say that systemic inflammation is a very early process in the pathophysiology of decompensation. It is already there in patients with grade 1 ascites. That is an ascites that can be detected only by ultrasonography. And then it rises progressively, moving to patients with grade 2, grade 3 ascites, and overall, please look at the scale in patients with difficult to treat ascites, patients with recurrent ascites, patients with refractory ascites. If the progressive increase in portal hypertension is the main change that we can observe in patients with compensated cirrhosis, in the green part of this graph, after the compensation, the main change is the progressive increase in the degree of systemic inflammation. So systemic inflammation is a powerful driver of decompensation. A third powerful driver is oxidative stress. This is the molecule of albumin that you all know. And you all know that in position 34, there is a residue of cysteine that is capable to bind ROS. Albumin is probably the most powerful antioxidant agent we have in the extracellular fluid. In doing so, albumin is oxidized either in a reversible form, human normal captoalbumin 1, or an irreversible form, human normal captoalbumin 2. And you can see that globally, the oxidized albumin is increasing progressively along the course of the liver disease. So for us, the problem was how we can put together progressively increasing portal hypertension, systemic inflammation, or oxidative stress. And some years ago, we proposed this new pathophysiological hypothesis, according to which nowadays we think that the main consequence of portal hypertension and liver failure is bacterial translocation. That is the real cause of systemic inflammation and oxidative stress, which are the real causes of the macrovascular dysfunction I mentioned before, and the consequent reduction of the effective circulating volume. There are no other mechanisms through which portal hypertension, liver failure can induce these relevant changes. And then systemic inflammation of oxidative stress, together with the activation of vasoconstrictor and sodium and water retaining factor, will cause the onset of ascites. How systemic inflammation can favor the onset of ascites? Let me show you that systemic inflammation will increase the sodium reabsorption at any level of the renal tube. And if we focus on the collecting duct, where sodium reabsorption is related to the activity of aldosterone through the activation of the sodium-potassium ATPase pump on the basolateral surface of the cell, making possible the sodium reabsorption through the sodium channel and the potassium efflux from the cell. Well, in the collecting duct, the pro-inflammatory cytokine will increase the expression of the gene of all the subunits of the sodium channel, and will also increase the expression of prostacyclin. What is it? It is the enzyme which activates the sodium channels. Let me go on. The consequence of systemic inflammation and oxidative stress is to generate a vicious cycle, further increase in portal hypertension, further derangement, impairment of liver function. So at the end of the day, there is a progressive increase in the degree of systemic inflammation and oxidative stress. So at any time during the course of the liver disease, organ failure may develop spontaneously in almost half of the cases, or as a consequence of a precipitating event at the hepatic or extrahepatic level. How systemic inflammation and oxidative stress can induce organ failure. We learned something from the omics. We know that this is a quite stressful situation in which there is an increasing lipolysis, glycolysis, proteolysis. So there is the production of a huge amount of energy substrates. But these energy substrates are shifted from the epithelial cell of the peripheral organ to where the immunocell. In addition, in other cells, nitric oxide, ROS, will induce an impairment of mitochondrial function, will induce mitochondrial damage. So, in a word, will impair the production of energy. So, when bacterial translocation occurs, there is an activation of the immune system that will produce a pro-inflammatory cascade with a shift of energy toward the immunocell. In addition, this will induce another production of nitric oxide and ROS, which on one side will induce the macrovascular dysfunction I mentioned. On the other side, the mitochondrial damage. And so I think that at the end of the day, hypoperfusion and the defect of energy will be the pathophysiological process that will induce the development of organ failure. But let me go now on the clinical ground. So let me highlight again acute decompensation. We know exactly that after the development of acute decompensation, the patient may follow 3 different trajectories. They may develop organ failure, so ACLF. They cannot develop organ failure, but can develop the major complication of the liver disease, requiring emergent hospitalization during the following 3 months. And we call this condition unstable decompensated cirrhosis. And finally, they cannot develop organ failure, and they cannot develop major complication of the liver disease, and we call this condition stable decompensated cirrhosis. More in detail, 1/3 of patients develop acute-on-chronic liver failure after acute decompensation, with a mortality rate at 3 months that is around 54%. 1/3 develop unstable decompensated cirrhosis, with a mortality rate at 3 months that is around 21%. And more than that, develop stable decompensated cirrhosis, with a mortality rate not at 3 months, but at 1 year, less than 10%. So we know very well what happened after the development of acute decompensation. What we don't know is what there is on the left side of this slide. So let me highlight our definition of acute decompensation in the canonic, in the predict, in the ACLF study. We define it as the acute onset of one of the major complications of the liver disease: ascites, bleeding, hepatic encephalopathy, and bacterial infection. Literally, we repeated the word acute 4 times in the definition, and all these patients were hospitalized. Now, if we look to geometry, and particularly to the visual concept of symmetry, when we define a process, an event as acute, implicitly, we have defined another event, another process as non-acute. Does it make sense going to the clinical ground? Yes, because we have almost 11 million of decompensated patients in the world, and most of them are not hospitalized. So decompensation can be managed in outpatient. In our unit, the ratio between outpatient with decompensated cirrhosis and inpatient with decompensated cirrhosis every week, every month, every year is around 10-15 to 1. Well, let me go on, because we are not the only consortium that perform researches on decompensation. There is also the Padova consortium, and the Padova consortium proposed different definitions during the last 10 years. So first decompensating event, further decompensation. So let me summarize what we know on decompensation up to now. We know that decompensation will induce a dramatic change in the survival of our patient, with a median survival that will be reduced from 10-12 years to 2-4 years. More in detail, if we look to the data on which the Padova consortium proposed their definition, we can say that 5 different prognostic stages of cirrhosis were defined. Stage 1, compensated cirrhosis without varices. Stage 2, compensated cirrhosis with varices. Stage 3, bleeding. Stage 4, any decompensating event different from bleeding. And you can see on your right the 5-year mortality rate. So what is further decompensation? Further decompensation has been defined last year as the development of a second decompensating event, has been defined as the development of recurrent ascites, recurrent hepatic encephalopathy, recurrent bleeding, has been defined as the development of SBP, of HRS-AKI. And you know, further decompensation is, by definition, very, very dangerous. Its impact on survival is much more negative than that of the first decompensating event. This is true for the ascites, this is true for hepatic encephalopathy. So at the end, the further decompensation, that is the 5th prognostic stage, is associated with the 5 years mortality rate higher than 85%. I think that we should take into account some other aspects of decompensation. The impact of mortality is related to the severity of each decompensating event, in this case, hepatic encephalopathy. But one thing is more important: the clinical setting in which the decompensating event develops. Because if hepatic encephalopathy develops in the setting of acute-on-chronic liver failure, the mortality rate, not at 5 years, but at 1 year, is higher than 60%. If hepatic encephalopathy develops not in the setting of ACLF, the mortality rate 1 year is below 30%. So I think it is time to think about this different definition, to try to harmonize them. Because we want that the young researchers can do research based on the same definition. This is the only way to build science. Otherwise, we will build the Tower of Babel. And I think that we are at the dawn of a new day for the definition of decompensation. And we should start from a classification of decompensation into acute decompensation. You all know very well what it is. And non-acute decompensation, what it is. It is the slow, progressive development of ascites, the slow, progressive development of grade 1, grade 2 hepatic encephalopathy, the slow, progressive increase of jaundice. So last year, we had proposed this vision. In patients with compensated cirrhosis, the first decompensating event may develop in 2 different settings. An acute setting, that is acute decompensation, that will require hospitalization, and some of these patients then develop ACLF. But may develop in a non-acute setting, and this patient can be treated as outpatient, and we call this non-acute decompensation. We don't know the relationship in between that, but we know that both them can lead to liver-related death or the need of liver transplantation, as they are, or through further episodes of decompensation, including new episodes of acute decompensation, for example. We don't know which patient develop acute decompensation, which patient develop non-acute decompensation. We have some data. In our unit, we follow it for a long period of time, a large cohort of patients with compensated cirrhosis. 40% develop an acute decompensation as first decompensating event. 11% develop a non-acute decompensation as first decompensating event. Then, more than 40% who initially developed the non-acute decompensation then develop acute decompensation. So, the first question: do acute decompensation and non-acute decompensation have different impact on survival? We have some preliminary data. We can say yes. non-acute decompensation has a less negative impact on survival as compared to acute decompensation. Do you think that this sub-classification is important? We think so, because, outpatient with non-acute decompensation, in most of the cases, this patient has responsive ascites, have a high risk to develop acute decompensation and ACLF. The risk to develop ACLF is 40% at 1 year, is 29% at 5 years, and 41% at 10 years. But I'm speaking about the risk to develop ACLF. The risk to develop acute decompensation is almost the double. And the first predictor of the development of ACLF and of acute decompensation in this patient is ascites. Any type of ascites is a risk factor for the development of acute decompensation and ACLF, including grade 1 ascites. Now, we have the possibility to prevent acute decompensation and ACLF in this patient. How? By the long-term use of albumin. This, I think, is the real message coming out from the Answer study. I think that the most important message is not that the long-term use of albumin is capable to reduce the probability to develop recurrent ascites. The most important message is that the long-term use of albumin is capable to reduce the risk to develop SVP, infection other than SVP, severe hepatic encephalopathy, renal failure. We are saying that the long-term use of albumin is capable to prevent acute decompensation and even ACLF. And I think that through this effect, it was possible to see that the long-term use of albumin was capable to improve survival in patients with non-acute decompensation. One may say, but this is a controlled clinical trial. What about the real evidence? Well, we can say that we performed a large real evidence study in Italy comparing long-term use of albumin versus non-long-term use of albumin. And you can see that the long-term use of albumin was associated with the reduction of the risk to develop the same complication I mentioned in the Answer study. Well, what we are doing and what we have done, next year we will have the result of the Preciosa study. In this study, we randomize the long-term use of albumin versus the standard of care in patients who have already developed acute decompensation, with the first aim to reduce the probability to develop ACLF and to improve 1 year survival. In this study, we have used a very high dose of albumin, 1.5 grams per kilo body weight every day. Why? Because this was the only dose associated with a significant, stable anti-inflammatory action. When we speak about the long-term use of albumin, in fact, we don't think about the oncotic property of the molecule. We think about the non-oncotic property of the molecule. There are several. I mentioned it before, the antioxidant action. Let me focus on the anti-inflammatory one. Albumin is capable to go into the immunocell, leukocyte, mononuclear cell, particularly in the pro-inflammatory state as a result of the administration of a pump, as in this study. The green points within the cell are the molecules of albumin. And within the cell, albumin are capable to prevent the production and the release of the most powerful pro-inflammatory cytokines, so exerting an anti-inflammatory action. Not only this, but albumin is capable to prevent the inflammation-related damage in epithelial cells. These are culture of human hepatocytes. On your right, untreated, in the middle, treated with two toxins, LPS and D-galactosamide. On your left, the culture was pre-exposed to human albumin and then exposed to the same true toxin. The brown area that you can see in this slide are apoptotica. And you can realize that the pre-exposure of a hepatocyte to human albumin was capable to reduce the severity of apoptosis. Why? We think that albumin is capable to prevent the release of cathepsin B from the lysosome, preventing the mitochondrial damage, preventing the activation of the caspase cascade. Well, you may say, this guy is coming here speaking about the anti-inflammatory action of albumin on cell. What about the experimental model of decompensated cirrhosis? I'm very proud to show you some result of my lab that we got before the description of the ACLF. These are rats with cirrhosis and ascites, and you can see that the administration of albumin was capable in the cardiac tissue to normalize the expression of TNF-alpha protein that was increasing baseline condition as compared to the control animals. Through this effect, albumin was capable to normalize the expression of inducible nitric oxide synthesis. So was capable to normalize the overproduction of nitric oxide that is a very negative molecule for the cardiac contractility. And so through this effect, albumin was capable to restore the cardiac contractility that is depressing baseline condition in this experimental model of decompensated cirrhosis. You cannot achieve the same result giving an artificial colloid. Again, you can say, this guy is coming here speaking about experimental model of decompensated cirrhosis. What about patients? The same result was obtained 10 years after in patients with acute decompensation. You can see that albumin is capable to restore the cardiac index. But if you look to this slide carefully, you can realize that there are patients who are responders to albumin and patients who are not responders to albumin. And this is true also for the ANSWER study. In the ANSWER study, there were patients who had benefit from the use of albumin and patients who didn't have benefit from the use of albumin. So I think that if we are able to find new biomarkers that can predict the patient who will be responders to the treatment, this will be a great achievement because albumin is not a magic potion. We are not enough albumin for all decompensated patients. And if we want to sustain the use of albumin as a sustainable therapeutical option, we should be very selective in the indication, very properly the use. We should remove the barrier for the long-term use of albumin. We should improve the quality of the product. But overall, we should find biomarkers that can predict who will be responders to the albumin. And this is the main target, I think, of the micropredict. Then we will have patients that will not respond to albumin. So we should find some other treatment, probably some combination of treatments. And I think that this will be the main target of the decision, and particularly of the COMBAT trial. Let me go. Micropredict and decision are great research problems. But we should realize that even if the trial at the end will be positive, we are treating a minority of patients with decompensated cirrhosis. We should be aware that we should not miss the main endpoint, that is prevention of decompensation. This is important because prevention is better than cure. And the first who said this sentence is a professor of the University of Padova, where you are today. But I don't say this only just to highlight this aspect. I want to say that during the last 30 years, we failed in the prevention of decompensation. If we look to the ratio in between decompensated and compensated patients, during the last 30 years, the ratio didn't reduce. The ratio increased. And now, going back to the Paveno consortium, last year they proposed to start the prevention of decompensation. I'm saying decompensation, not bleeding, on the basis of non-invasive tool. So you should start the prevention of decompensation in patients with liver stiffness higher than 25 kilopascal, or in between 20 and 25 with a low platelet count. Why? Because this patient has a clinical significant portal hypertension. And we know that the use of propanolol or carvedilol is capable in this patient to reduce the risk of decompensation. But I want to ask you, you want to really rely on propanolol, on carvedilol alone for the prevention of decompensation? I'm speaking about a pill for which we are not able to measure its effect on the parameter we want to change, that is portal hypertension. This is the big elephant that we have in the room in the prevention of decompensation. So there are some other minor points. For example, in the definition of acute decompensation, I mentioned the acute severe bacterial infection. But bacterial infection can be considered a decompensating event, or is it a precipitating factor of decompensation? This is another point. There are other points I have no time to go into, but let me focus on bacterial infection. In my mind, a decompensating event is a complication of the disease with a high prevalence, with a strong link to the pathophysiology of the disease, and with a strong impact, negative impact on the outcome. This is, in my mind, the definition of decompensating event. Now, in patients with cirrhosis, we have a lot of complications. The problem is which complication among these can be qualified as decompensating event. Historically, different parameters have been used to define decompensation. The most commonly used were ascites, hepatic encephalopathy, and bleeding. But you can see that sometimes it was used also jaundice, sometimes hepatocellular carcinoma, sometimes an increase in the CDP score. The larger number of parameters for the definition of decompensation, the higher prevalence of decompensation. But let me focus on the parameters that were most commonly used. So, ascites, bleeding, encephalopathy, and jaundice. All them has a high prevalence in patients with cirrhosis. All them are not specific. All them has a deep negative impact on survival. All them have a strong link to the pathophysiology. What about bacterial infection? Very difficult. Bacterial infection has a prevalence in cirrhotic patients 4-6 times higher than in the general population. They are not specific, with only one exception, that is spontaneous bacterial peritonitis. They all have a negative impact on survival. They have a strong link to the pathophysiology, particularly SBP. So, how we should consider that? As a decompensating event, as a precipitating event. I have not a clear-cut solution for this problem. And I go to my take-home messages. The pathophysiology of decompensation is much more complex than the simple progressive increase in portal hypertension. We think that there are two different patterns of decompensation, acute decompensation and non-acute decompensation. More than 40% of patients will initially develop non-acute decompensation, then develop acute decompensation. The long-term use of albumin in patients with non-acute decompensation prevents the development of acute decompensation and ACLF, improves survival and quality of life. Albumin is exerting an anti-inflammatory and antioxidant action. And finally, we should develop new, update, preventive strategies for decompensation in patients with cirrhosis. And thank you very much for your attention.